Gadomski. And we also have a participant, a patient participant who will be joining us to tell us about her lived experience. So I hope that you all enjoy this workshop. I'll start with Dr. Ketcham. Dr. Ketcham actually serves as an emergency physician and addiction specialist, both inpatient and outpatient for the Presbyterian Health System in Santa Fe and Espanola, New Mexico. He's the director of an opioid addiction treatment clinic in Farmington, New Mexico, board certified in addiction medicine, and currently works with methadone, buprenorphine, and naltrexone. He's testified before Congress, and we're really pleased to have him as part of our community in New Mexico. We've spoken on the phone, Eric, but never actually met in person. So it's a pleasure to welcome you.
Thank you.
Please just get started. Do we have your slides, Eric?
So I guess I've had a miscommunication of what I would be doing this presentation today, but so I didn't prepare a slide presentation specifically for this talk, and I'm sorry if I missed some communication. Thought I was going to be answering questions on a panel, but I got lots of different slide presentations and a lot of things we can talk about, and I've got a great slide presentation I'd love to put up right now to talk about using naltrexone to treat alcohol use disorder in the emergency department.
We'd love to hear that.
Well, then give me just a minute and I'll put that up.
And we'll make sure that you have access to share slides.
All right.
So while we are going to be talking, Rich Gadomski is going to be talking about buprenorphine. I'll introduce him when it's his turn. And we are going to talk to our patient participant. There are other treatments for opioid use disorder and alcohol use disorder besides buprenorphine and methadone, and one is naltrexone. So I actually don't know enough about naltrexone, so I'm going to let Eric take it away. The delay is okay because many people are still joining. You're muted, Eric.
Can y'all see my screen now?
Not yet. There we go.
All right, super.
Terrific.
Okay, well, what I really like to talk about then is our most recent intervention that we've introduced at Presbyterian. We've been using buprenorphine in the ED for a couple of years now in Santa Fe, Espanola, and our press facilities in Albuquerque, so downtown, and at Rio Rancho, at our Rust facility, and at Caseman. And so, interestingly, I've been using naltrexone in the emergency department for about 2.5 years myself, and longer on the inpatient units. I really think it's a potentially life-transforming medication for alcohol use disorder. And in fact, I'm probably administering doses every day on our inpatient unit for sure. And we had a discussion of kind of updating on where things are going with buprenorphine. And interestingly, I was surprised how many emergency physicians had really taken to the impact, or really impressed with the impact that we've been able to make with administering buprenorphine in the ED. And they really started to then ask about alcohol use disorder, and we did a brief presentation on it. And I think really because of seeing the difference we could make with opioid use disorder from the ED with buprenorphine, there was such an interest in believing that maybe we could make a difference in another substance use disorder. And that really brought about the discussion about naltrexone. And so as some of you may know, there's probably about 4 EDs around the country that have really been doing much with naltrexone, and really just in the last 2 to 3 years. So we went live with this program in June in Santa Fe, Espanola, and all our 3 downtown or Albuquerque emergency departments. So that's where we are right now. We're still working out bugs, and I'll kind of talk about that in just a minute. But this is a is the talk that gave and when we first started talking about this. And so I have no conflict of interest, although I certainly know the folks at Alchemy as well who make the product. I got no financial relationship with them. And in this talk, we talk about the basics of AUD, a little about the mechanism of naltrexone and why it's effective for treating alcohol use disorder, and particularly as a depot injection rather than as an oral tablet. And then we talked a little bit about our exclusion criteria, treating withdrawal. And then of course we go into the process of how you order through Epic, which I'll skip that for this presentation. But that's an important part when you're explaining to emergency physicians the nuts and bolts of actually, ordering the drug, right? So as a background, we talk about opioid use disorder all the time, but the truth is alcohol use disorder is still killing more people than opioids in this country, although opioids have become a pretty close second now. And unfortunately, alcohol use disorder, in New Mexico, we lead the nation in alcohol use disorder related mortality per capita. So for a long time, we know this is evident in the emergency department. This is what we do every day. We have people sobering up who are intoxicated. We have a lot of interpersonal violence that presents, as well as motor vehicle accidents and people presenting with GI bleeds and a lot of other complications of alcohol use disorder. And other than addressing acute medical or trauma-related emergencies, we really didn't do much more for them. We may give them medication, to help them with a brief period of alcohol withdrawal, but as far as really linking people to treatment and beginning a long-term medication is something we just haven't done. So brief description of where alcohol works. Well, it works at this thing called the GABA receptor. And a whole lot of other things work at the GABA receptor as well, like volatile anesthetics and propofol and benzodiazepines and also, of course, barbiturates, right? And, you can see the effect on the global reduction of metabolism when we have somebody intoxicated, versus when they're sober. And this is a basically a flow MRI study. And just to talk briefly, more about sort of what's going on a metabolic level, right? As alcohol drives down this regulation of GABA receptors, depletes GABA stores, it takes away the brain's inhibitory brake, which is why, of course, alcohol withdrawal can cause seizures. And but this is really explaining what's going on with alcohol intoxication and a little bit about withdrawal and seizures related stuff, but it doesn't really explain how we help treat it with medication. But once again, just a brief explanation of what goes on here. The body has to balance out the presence of alcohol, and it has to balance out alcohol, which is a CNS depressant, with something that's more neurostimulatory, and that's known as glutamate. And so the problem is then, now that you've ramped up all this glutamate, if you take away the alcohol, you get this tremendous imbalance, which creates this hyperexcited state, right? But when it comes to cravings and why people drink in the first place, other than when they're trying not to go through alcohol withdrawal, it has to do with what's going on in the nucleus accumbens and this pathway to the nucleus accumbens known from the VTA. And this pathway is essentially what causes dopamine to be dumped in the nucleus accumbens when people drink alcohol and why people crave alcohol. And so naltrexone, which, as we know, was designed to treat opioid use disorder, right? It profoundly blocks the effects of opioids at mu receptors. So with alcohol, what it does is it works as a very specific mu receptor. And this is known as this mu OPR receptor here, which essentially is where endorphins, this beta endorphin acts. And with the effect of naltrexone, it stops the impact of this beta endorphin. Otherwise, the beta endorphin inhibits the flow of GABA. So by using naltrexone, it allows GABA to do its thing. And therefore, GABA prevents the dumping of dopamine through this mesolimbic pathway into the nucleus accumbens. And I think it's important to understand the neurobiology just a little bit, because it's kind of counterintuitive. If this was designed to treat opioid use disorder, what is it doing to treat alcohol use disorder? And this is something, of course, we found out later, right? The drug was created to treat opioid use disorder. It was created to block mu receptors. It's very effective at doing that, but we only learned later and came to understand this effect later in time. So naltrexone is very effective at reducing cravings. It really helps people, particularly who want to stop drinking, drink less. There's a daily dose that's effective between 50 and 100 milligrams, and there's also an injectable formulation of 380 milligrams, which is the IM, a monthly dose. And for folks who receive this on a regular monthly basis, and really it's less than monthly, it's between 3 to 4 weeks. And some people can go longer, some people less. It can really profoundly decrease alcohol cravings and really help people stay in recovery. But you just have to make sure, of course, they don't have a co-occurring opioid use disorder, although it can treat that, but they can't, be using opioids recently if they're opioid dependent. So reduces alcohol cravings. Far more effective, though, if they receive this as an injectable formulation. The oral medicine is effective, but only if the patient takes it every day. And the challenge is to take the oral medicine every day. You have to have this level of insight, of readiness, of confidence, and a lot of peer and social support, which is often lacking, particularly when we're first initiating treatment. And many patients can graduate from the injectable form to the oral form later, but folks just tend to do a lot better, at least for the first few months, receiving this as an injection. The good thing about naltrexone, they don't need to withdraw first. In fact, I give it to patients while they're still intoxicated sometimes, as long as they're sober enough to be able to consent and request treatment. But the thing about it is, it takes away cravings, so you really have to focus on preventively treating their alcohol withdrawal, right? Because it doesn't treat withdrawal, right? It just treats cravings, and many patients then will forget to take medicine for alcohol withdrawal until they really start withdrawing. So you have to proactively focus on preventing their withdrawal when you're administering this medication up front. So I also always give my patient a prescription for oral medicine because it decreases breakthrough cravings, and it will help bridge them if they didn't get their next injection lined up when we wanted them to. So they've got the oral medicine to fall back on until their next injection gets scheduled, or until they're able to get to it, or for whatever happened that they didn't get it. So you can be a binge drinker, you can be a daily drinker. A lot of our patients who really have problems with alcohol use disorder are actually binge drinkers. They may be sober for a few weeks at a time and then they drink, but they incur just as much damage to their lives, on an alcohol binge as if they were drinking every day. So all they have to be interested in is sustained recovery, sustained sobriety, and they really can qualify for this medication, assuming that they don't have any metabolic contraindications. So for our group we're doing with Presbyterian, we're really not focusing on a homeless population right now, although occasionally we are treating that patient population. We just need to know, do they have a transportation resource? Can they fill a prescription? And if they can do those things, a lot of times our patients can do well with this medicine. And some of our patients who are homeless are just homeless because they're not allowed to stay with their family when they're drinking, right? So you get them to stop drinking and they may find a place to stay. They can't be opioid dependent, at least not at the time of initiating this treatment, and they can only have mild to moderate liver disease. And these are parameters we set for the emergency department, which are pretty conservative. I certainly give this medication to patients who have a much higher bilirubin in the hospital, or higher AST and ALT. We've tried to set conservative limits so the emergency physician doesn't have to get too cerebral thinking about if their patient's going to qualify. And we know that naltrexone can be hepatotoxic, but the bottom line is it's far less hepatotoxic than ethanol, right? So it also they have to be insured. If they're self-pay, then it's hard to arrange follow-up injections. The injections we give in the emergency department, by the way, this thing called the HIFT program by the manufacturer, Alkermes, we get all this medication free to administer in the inpatient unit and in the emergency department, and this program is nationwide. So, if UNM is thinking about doing this, I'd be happy to talk to y'all about it. It won't cost you anything as far as the medication goes. The oral medicine is also generic, and it's pretty darn cheap. So it's been around a long time, obviously, right? Most patients tolerate this medicine pretty well. There are some other effects. It is an appetite suppression. In fact, naltrexone is sold. It's marketed as an appetite suppressant. So some people, in fact, get this medication prescribed orally just to help them lose weight. It can cause some increased depression for some people, can cause some headaches, some insomnia, and some nausea for some folks, but most people tolerate it pretty well. If they have problems with insomnia, I often will try to pair it with gabapentin to help them sleep, and I'll try to make sure if they're taking it orally, they take it in the morning. I've only had one patient who just refused to keep getting the injection because he lost so much weight. He lost like 80 pounds, and he was afraid that he was going to get too skinny. But most people don't stop taking the medicine because of appetite suppression. The most, in fact, common reason that people will not get another injection, it's because of pain at the injection site, and this can absolutely be avoided by proper technique. It's very technique sensitive, and as long as you train your staff really well on properly mixing at the bedside and administering the right location, then patients tolerate it pretty well, and they'll gladly get their injection every month. And I can tell you, for some of my patients who get their injection every month, this is the difference. When they stop taking their injection, they're in the emergency department, they're getting admitted to the hospital again and again, and as long as they're getting their injection, they're living a normal life, so this can be absolutely life transforming. The key is, of course, we have to help our emergency physicians and hospitalists and such have this conversation, right? Because a big part of being engaged in treating substance use disorders is you got to learn to talk to your patients. And as Winston Churchill has said, and I like to use this quote, you know, courage is what it takes to stand up and speak, but courage is also what it takes to sit down and listen. So these are kind of my tips that I try to relay to my physicians and our peers. I know some peers on the call today, you know, they're really great at this. And but I get these comments frequently from other physicians when I'll tell them, well, this is what the patient's doing. Say, well, how'd you get that information from the patient? I just asked the patient, that's all, you know. So if they believe you care and they think you're listening, they'll tell you anything you want to know. So my recommendation is always, I try to sit on the lowest thing in the room. I always make sure that I'm sitting lower than them in their hospital bed, in their ED cot or stretcher. And I just ask them, may I ask you about your drinking? And or could we talk about your alcohol use? I like to make sure the patient feels they're in control of that conversation. They can decline if they'd like to. And then I listen to them and I ask them about their opioid use first. I want to make sure that that's not going to be a contraindication. And then, you know, we talk about their alcohol use and if they're interested in treatment. And this is the key line. This is the way I phrase it every time because this is critical, is if I could give you a medication which blocks the cravings of alcohol but doesn't make you sick if you drink, would you be interested? And most patients are pretty darn interested when you tell them that. And most patients have, if they've taken medication in the past, they have an experience with disulfiram and they really don't want to take Antabuse. So, and then from there, you know, these are kind of the key things. We explain how it works. You don't have to go into a big pathophysiology, pharmacology explanation, but as long as they understand it blocks the cravings, doesn't make them sick if they drink. That's really all I need to know. And as they understand it, you know, works in the brain. And we talk a little bit about how it's better to receive the medication through an injectable formulation if possible, how we'll set them up to get follow-up injections. Now we do this through our infusion centers so that they don't have to come back to the emergency department and they don't even have to have a clinic appointment necessarily. This is a nurse clinic, and so it runs pretty efficiently. And then we talk a little bit about alcohol withdrawal, and I make sure they understand it's important that we treat this right away, that we start them on medication before they leave the emergency department. If they're, many patients are going to show up to ED withdrawing already. So already treating the withdrawal while we're doing this. But sometimes you have patients, they've just been sobering up. A lot of patients I treat, they're just sobering up. I only work night shifts. And so at the end of my shift, I'm waking people up and talking to them about this. And I probably give this almost every shift I work in the emergency department, at least 2/3 of them. And sometimes I've given it to, you know, more than one patient. So there's plenty of patients out there, as long as you get with it and understand this. So this is just a brief side note. This is just to remind everybody that the New Mexico Poison Center, by the way, is available 24/7 to take calls about opioid use disorder and about buprenorphine and kratom and initiating buprenorphine in the emergency department. So the rest of this slide presentation is me walking through a lot of stuff on the order set, which I will skip through. But you know, when you set this up, the key is to try to make this as simple as possible. And I will tell you that we've made this a little too complicated at Presbyterian. We're doing pretty good as far as understanding the medication, but this referral to treatment, we have to change the plan because that's often what makes programs succeed or fail, right? How easy can you make this for your providers to do? And I think as far as the referral to treatment process, we've made it too complicated. We have another meeting tomorrow, and my goal is to just stop getting them to try to do this. Just get them to give the medication, let's track the data, and then we should take care of all the referral to treatment. And I think we'll get more folks engaged in doing it. That's my impression so far. So as you can see, just the slides explaining how to do it. You know, that's a lot of slides. I will say this though, I really try to emphasize using gabapentin as our primary medication to treat alcohol withdrawal. I also run an alcohol, I hate this word, detox center, but you know, a center where we focus on managing alcohol withdrawal and engaging people in treatment. And I only use gabapentin. I reserve benzos just for folks who are having breakthrough withdrawal as measured on a scale. We also have carbamazepine Tegretol as a secondary option. We discharge the patient with a prescription for gabapentin in addition to initiating the EDs or a prescription for gabapentin, or excuse me, carbamazepine. And of course, you know, if you want to prescribe patient vitamins, you know, I'd say that's great, that's a bonus, but you know, you can give them thiamine and folate, but if you just get them to stop drinking, they'll eat real food, and that'll make a bigger difference than giving vitamins they're not going to take if they're actively drinking. So, you know, more things about making sure we're referring them to peer support as well as post-treatment navigation. We'll keep that, but I think we're going to scrap all the all the process of trying to explain how to refer people to the infusion center, I think it's a barrier. And there you go. That's my that's what we're doing for alcohol use disorder at Presbyterian right now. So
Eric, that was great to hear. We are going to have questions at the end, but there is one question
yes.
that we have in the chat box right now. You mentioned that the effective duration of intramuscular formulation of naltrexone is 3 to 4 weeks. Does insurance cover it at this frequency or only once per month?
So first of all, if you have Medicaid in New Mexico, there's no PA required anymore. So naltrexone, like buprenorphine, is fully covered by Medicaid. So the PA process is really short. I'm not sure it really is a PA. There's more of an issue of the ordering process. So like if you're a Presbyterian patient, even at a Presbyterian facility, then I have to still call in the prescription to our special pharmacy. It's, it's kind of annoying. But yes, they will do it at shorter intervals. So I have some patients feel like this medication lasts them 6 weeks or longer. And some really know when they're hitting that 4 weeks, and they know when it's wearing off, or they know when they're getting close to 4 weeks. And I have other patients that I have to dose them at every 3 weeks, or I swear once 3 weeks is over, they're drinking again and they're back in the emergency department. So, but we found so far that Medicaid is covering at intervals as short as 3 weeks.
That's great. I appreciate hearing how well you listen to your patients and want to remove the barriers. I'm going to move on right now to Dr. Gadomski.
Gadomski.
God, I'm sorry, Richard.
No worries.
Richard Gadomski is from New York, where he actually studied political science and economics at Colgate. He subsequently did a postbac at Harvard and attended medical school at University of Maryland School of Medicine. I know Rich from when he attended his preventive medicine residency at the University of New Mexico. He's trained extensively in addiction medicine clinically and really is very interested in the opioid epidemic from a public health perspective, especially since he's earned his Master's of Science in Clinical Research. He's now faculty at the University of New Mexico in the School of Medicine in the Addiction Division of the Department of Psychiatry. And he splits his time between clinical care and teaching in the addiction and substance use program at FACEP with another group of wonderful people, and a low barrier buprenorphine program, which he initiated in conjunction with an existing harm reduction center in Rio Arriba County, which does and continues to have one of the highest fatal opioid-related overdose rates in the country. We're very happy to have Rich join us and to tell us about this low threshold program.
Thanks very much, Kim. I appreciate it. Thank you for having me. I'm just going to go ahead and share my screen.
The first question we usually get is, what's a low threshold program?
Yeah, let's talk about that. Can you guys see my screen? Great. Sorry, the Zoom bar is in my way here. Just going to bring it down. Okay, so I'm talking a little bit about a new model that we're trying to pioneer regarding low threshold, low barrier buprenorphine in combination with a comprehensive, tailored set of services for people with opioid use disorder and people who inject drugs. And I'll definitely explain that a bit more. Nothing to disclose. And first, I just wanted to give a special thanks to a lot of people who made this project possible, including Neil Bowen and Tiffany Wynn at BHSD, Julie Salvador and Snehal Bhatt at UNM, and Tony Dixon and Phil Feudy at the Mountain Center. These are just a couple abbreviations that you'll see, but we don't need to go over this in detail. So I think it's important to keep in mind that 2020 saw 93,000 fatal overdoses, which is a 30% increase from 2019, certainly exacerbated by the COVID epidemic. And this is higher than at any point since the opioid epidemic began in the 90s, higher than the fatalities caused by HIV before antiretrovirals were available in the 80s. 2019, leading cause of death under the age of 50. So it's something to keep in mind. And as Kim mentioned, Rio Arriba County is pretty high up there in terms of fatal overdoses. Espanola is particularly unique in that it has a generational opioid epidemic and very high rates of trauma, which is driving continued use. So I think there's a pretty well-established, if not growing, consensus that the status quo in terms of how we're approaching the opioid epidemic, at least from a care delivery perspective, is not really acceptable and not making that much of an impact the way that we'd like it to. So just in terms of the background, real quickly, for buprenorphine, detox from heroin is good for many things, but staying off heroin is not one of them. And that's where the FDA approved medicines for opioid use disorder come into play, including naltrexone, methadone, and buprenorphine. So this is a slide that I borrowed from my colleague, Dr. Bott, but basically what this is showing is that if you compare people who've detoxed straight off of, for example, heroin versus people who are initiated on buprenorphine treatment, you can see that the retention in treatment over time was much more significant than those who detoxed. And retention in treatment has a very high positive correlation with prognosis with opioid use disorder. And in fact, those who detoxed, we saw 4 deaths in that group versus 0 deaths in the buprenorphine group. So low barrier buprenorphine as a treatment modality concept, it's pretty straightforward. It's what it sounds like. We're trying to remove as many barriers as possible to buprenorphine access. This model is also called a low threshold model in that there's a low threshold to initiate treatment diagnosis of opioid use disorder. Although in my opinion, that should really apply in any treatment setting. So buprenorphine is a first-line medicine for opioid use disorder. It's safe, especially as a partial agonist. It's safer than methadone and other few full mu-opioid agonists. But the problem is that the availability and the access to this life-saving medicine is severely restricted. And what we're doing up in Espanola is, at least in part, is approaching it from a harm reduction perspective. So since this is such a safe medicine, as long as you're not combining it with other opioids, alcohol, or benzodiazepines, very much like we're trying to just get Narcan out the door and saturate the population with Narcan, it's a similar thing that we're doing with buprenorphine and trying to address the overdose crisis from that standpoint. So first, buprenorphine, from a harm reduction perspective, helps prevent overdose. Secondly, I think it's important to keep in mind that buprenorphine empowers people to break the cycle of using and withdrawing so that they can focus on other priorities in their lives, like relationships, jobs, housing, etc. So I wanted to talk a little bit about harm reduction because a critical aspect of the project that we're doing from the inception of the project was that we housed our clinic in an existing harm reduction site and a syringe exchange, which is rather unique. And I'm just going to read this because it's a better definition than I could, do off the cuff. So harm reduction is about offering options that can help people. It includes stable housing, access to life-saving drugs like naloxone that reverse an opioid overdose, drug checking that can detect adulteration in the drug supply, syringe exchange services, and connection to a bunch of other services and that can really make an impact in people's lives. And like I said, so we're co-localized with a harm reduction syringe services provider, the Mountain Center, up in Espanola. And this is really critical because the opioid use disorder population is traditionally a difficult to reach, difficult to engage population. And the harm reduction site represents a place where this population has a sense of community, has already established a sense of safety. And this is really fostered in part by the harm reduction philosophy, which involves meeting people where they are, non-judgmental, low pressure approach. So building on the harm reduction, the existing harm reduction site, we've now tried to complement it with a full menu, full spectrum care model tailored to the needs of people who inject drugs and people with opioid use disorder. And we feel like this is a novel, progressive, and aggressive way to tackle the overdose crisis and related morbidities such as hepatitis C and HIV, et cetera. And we're proud to say that we doubled the amount of active patients in the first 6 months. So I'm just this is kind of a busy slide, but I'm just gonna go through and give you guys an idea of the services that we provide, which are, again, really tailored to the needs of this specific population. So I'm doing full psychiatric prescribing, including schizophrenia and bipolar. We're prescribing buprenorphine, obviously, and we've recently added Sublocade, which is great, especially in terms of people who have difficulty adhering to daily medications, whether it's homelessness, other types of psychosocial instability, and especially in Rio Arriba County, which is a rural county, access to transportation can be difficult. Secondly, we're offering counseling, including trauma-focused therapy. I think a lot of us have the understanding that, well, at least at ASAP, 70 to 80% of our patients with opioid use disorder have PTSD and trauma, and they're self-medicating that trauma with opioids in the first place. So treating that simultaneously is very important. As I mentioned, the harm reduction component is very robust, very important to what we're doing. We also offer peer support and case management services in order to help facilitate and optimize people's recovery. And in terms of targeted medical services, I'm pretty excited that we recently got going with our first hepatitis C patient, and this is facilitated with ECHO support. We're also doing HIV treatment with antiretrovirals with ECHO support, particularly with MSM patients. Similarly, we're offering PrEP and PEP, which obviously is certainly in the wheelhouse, so to speak, of our patient population. We're offering a little bit of primary care with referral pretty much as quickly as possible to one of the FQHCs nearby. For example, El Centro does a great job in that community, I think. A little bit of birth control if people are interested. And one of the big things, one of the big challenges is wound care. There's not a huge amount of options for that in Española or Rio Arriba County. And, you know, injection related wounds, chronic wounds are pretty prevalent. So we're still working on how to fix that problem. So challenges, you know, I don't need to remind you necessarily that stigma is an enormous barrier, and it comes in many forms. So I think certainly in Rio Arriba County, but all across the nation, there's a prevailing public narrative about addiction as a moral failure and a choice rather than a disease process. And that can really be problematic in terms of people seeking treatment. You know, there's certainly discrimination and stigma on the part of providers, you know, all over the state and all over the country for sure. And then patients have internalized stigma as well, which prevents them from reaching out for help in terms of buprenorphine, for example, because they feel like it's trading one crutch for another, and that they're basically just doing the same thing and kicking the can down the road. So as I mentioned, patient retention for projects like this is traditionally not as high as we would hope, but patient retention is very important for prognosis. Some of the reasons that we struggle with that, I think, has a lot to do with the specific population in Espanola, but also the OUD population in general. There's a lot of psychosocial instability, and opioid use disorder and addiction by their very nature is a chronic relapsing disease. And again, there's stigma issues. From a public health perspective, I think there is a lot of lack of awareness and education around effective treatment. We ran into some issues getting up and running in the COVID, which is a difficult operating environment, certainly. And one thing which I want to make sure that I emphasize for this group is that pharmacy level barriers, particularly in Espanola, but I've also seen them in Albuquerque, are really significant, where we send people, we send a script to the pharmacy, people show up at the pharmacy and they've run out of Suboxone, which is, certainly very counterproductive when there's all these efforts around the state to increase the amount of providers prescribing Suboxone, increase the amount of scripts that are written. But then at the end of the equation, they just can't pick it up because they've run out. I've seen pharmacies starting wait lists, et cetera, which I just is kind of mind blowing for me. And then in terms of future directions and sustainability for the project, we've received a second round of funding from BHSD through September 2022. And our plan is to start billing Medicaid pretty aggressively so that we can become fully sustainable. And we're hoping to expand as well. So I think that's about it for me, and I'm happy to open it up to questions or wait my turn or whatever is appropriate.
Thank you, Rich. It's really just outstanding work. This is the kind of thing people write about, as a wish list, and it's wonderful to see what's going on.
Thank you very much.
Yeah, it's really just terrific. I think we'll come back to you for questions, and I'm going to introduce our patient participant, Lynette Kelly, who is here to share with us about the life-changing experience that she had with Suboxone, and since she started it. Her addiction began following a series of surgeries, and in 2019, Mrs. Kelly was invited to share her story with the Surgeon General, Dr. Vivek Murthy. We're very grateful to you, Lynette, for sharing your time and expertise with us, and I'll turn it over to you.
Okay. Hi, everybody. My name is Lynette Kelly. And first off, I want to thank the two doctors that spoke, because I really wish I had a doctor like you guys back then, as far as you both kind of, asking, like, would you want help? That's one of the things I didn't get. Again, it was like over 13 years ago. So I've been on Suboxone for about 13, 14 years. Pretty much, I had my wisdom teeth taken out. I had a knee surgery and a broken foot all within a matter of 3 months. So I was just getting thrown pain pills. I knew about the stigma of addiction, but I just didn't, I had so many of them that I figured, I'll be fine. I didn't know like what withdrawal was or anything like that. I grew up in a great family. Unlike, a lot of unfortunate people don't. So that's like why a lot of people ask me, like, how did you even get addicted to this? I remember the first time I ran out and withdraw it, I was like, I wanted to die. It was horrible pain. And I think that's what just kind of kept me going. Long story short, with all that, I would go see different doctors to get them. And one thing that probably saved my life was when everybody started doing the contracts, because I was taking up to 30 pills a day in the last 2 years of my addiction. And there was one point where I had to do the contract, and of course I ran out of those in about 2 days. And luckily, the doctor that I went to see to get more, he was actually working at ASAP, or he had worked at ASAP, and he was the one that actually first told me about Suboxone, because of course, you know, I ruined the contract there. So I knew in the back of my head about Suboxone. I was doing research about it. And then at the same time, I was kind of ashamed, like, no, I could do this on my own. I think 5 different times I tried cold turkey to stop. And I think the most I made it was 3 months, and I was still absolutely miserable. The physical pain went away probably within a month, but the mental, just the craving, I'm like, I can't do this. So I finally opened up to my fiance, which I've been with for 16 years, and I hid all that from him for that long. I have no idea how. I opened up to him, and the next day he's driving me to ASAP at 4 o'clock in the morning. And I've been clean ever since. Hello?
Hi, Lynette. Thank you for that.
Oh, sorry, I didn't know if I got disconnected.
No, you're not disconnected. You're with
Okay,
us.
good.
It's really great to
Certainly
hear from you, and I really appreciate that you've been on Suboxone long-term. Very often patients who've been on long-term, and I know many of them, get a lot of pressure to go off of it. Do you experience that?
I've been asked, mainly not, like Dr. Jacobson is my normal doctor. I do get asked that when a lot of the teaching students come in, like the interns and stuff. Like, do you have any plans on getting off of it anytime soon? But they always say, like, if not, it's totally fine. You know, you just let us know. So not really pressure, but every time I get asked that, I'm kind of like, do I have to? Like, I don't. It's just kind of like a scary thing, because like I have been on it, but I feel normal. Like, and I remember the first day. I mean, I just the terrible pain, and it was just, I hated myself for like putting myself through this, and the point where I got, but I like physically, I just could not handle the withdrawal. So I guess my biggest fear, and they always say, you know, we'll wean you off slowly. It's just like another part of my day. Like, I take my thyroid pill, my, you know, birth control. It's just like another, it's not a problem for me, meaning.
That's how it's supposed to be.
Right.
I think. I will open this up. I have other questions, but I'd like to find out if the audience here has questions for you or Dr. Gadomski or Dr. Ketcham.
Okay.
You can raise your hand. Or put your question in the chat. I don't see any hands raised. Does anyone else? Well, while you think of questions, then I'll ask. And I want to come back to you, Lynette. And this is relevant to our physicians. What has really kept you going? We learned today from Dr. Gadomski and Dr. Ketcham, people who are new to medication often don't stay with it. And then they relapse. What are some good strategies for keeping people on medication who are new to it to stay in treatment? What do you think are some of the things that you would recommend to physicians about retaining patients?
Well,
If I could address that. Oh, go ahead.
Oh, sorry, go
ahead, Lynette, please
No.
speak.
No, go ahead. Oh, I was just going to say, for me, I was just so scared and miserable of the pain that I was going through. Like, I mean, I was working because after the contract gave up, I didn't tell you guys this. I left it out. I didn't mean to leave it out. I just forgot. That's when I started buying off the street. So I was buying bags of pills from coworkers. God knows what I was taking. At that point, mainly it was Vicodin, but at that point I was just taking whatever I could get. I was meeting shady people randomly, like sneaking out. Like that's not me. So for me, it was like, I want my life back type of situation. And the first day that I did take the Suboxone, I remember feeling just normal again. And that's what I tell people, like, if I hear from one of my friends or something that like somebody they know has a problem, I always tell them my story and just be like, it's amazing, you know, and especially if they want to quit. That's the problem. Because I was doing research about Suboxone for a long time, but at that time, and it might be easier now, at that time, I didn't really know about FACEP. There was only like a certain prescribed doctors that could give it to you. So it was kind of like making that appointment to go and say all that. So that was the one problem I had actually jumping in and doing it. But just that first day, I remember I was able to go have breakfast with my fiance for the first time. I was able to do laundry, like get up and do laundry like a normal person. So for me, that's what's kept me on it. And I just always tell that story, like, if this is helping you so good, why go back to what isn't?
That's really great. Donald Hume, you have your hand raised. Tell
Yes,
us where you're from and your question.
I'm Donald Hume. I'm peer support supervisor for peers in the emergency room and in the NICU that work with individuals that come in with substance related episodes. We work real closely with Dr. Ketcham. And I just wanted to say along the same lines is that whenever you're able to get a peer involved, a lot of times the peer is able to assist the patient in realizing that the benefits of staying on the medication. It's been proven and shown that medication adherence becomes a lot higher anytime that you have a peer involved with the individual, and even treatment adherence becomes a lot higher when peers are involved. So, you know, there are certain things that peers are able to do that kind of overreaches even what an amazing doctor like Eric Ketcham can do. And it sounds like Dr. Gabs. Sorry, I don't want to mess up your name.
You guys can just call me Rich and keep it easy.
Rich. And thank you, Rich, for also mentioning about having peers on the employed by the Mountain Center as well. I think that we are really able to overreach some of those barriers that get in the way.
Yeah, I think that's really well said, Donald. The lived experience is an X factor that really makes a difference for a lot of people's recovery. So thank you.
And yeah, for me, with the counseling, especially at the beginning, was really helpful for me also, just because you're able to see like other people going through what you went through. A lot of them had way worse stories than me. You know, and it just, that was especially important because I remember at first we would have to do like a group every week for, I believe it was like 9 weeks. And that was the beginning. And then it was like every month after that. So I think those group meetings at the beginning really, really helped me, just hearing everybody else's story.
That's great to hear.
What they went through. Right.
Yeah. Raquel Rivera, you have a question?
Yes, thank you. I'm Raquel. I work at Bold Futures, New Mexico, formerly known as Young Women United. And we do a lot of work with people with lived experience with substance use. There's a group of them actually now that are participating in the Improving Perinatal Maternal Health ECHO program. So I know, more like from the policy and organizing side. So when I heard Dr. Gadomski talk about the harm reduction approach, and like I've just been assuming that the harm reduction approach is the approach. So suddenly it doesn't sound like necessarily it is. And I'm just wondering, like, how accepted is it? Is it the dominant approach? And there's some people, like resisting it, or
Hey,
like,
Raquel,
yeah.
sorry, I noticed that Philip Feudy joined us, and he's kind of like the harm reduction specialist, if he'd care to, I don't know, chime in.
There we go. Well, I mean, I'm really happy to hear that it's just, there's somebody out there who was just like, oh, this is how we do things. Because it hasn't always been that way. So did you have a specific question again?
Yeah, just to get a better sense of where our society, maybe we can just talk about New Mexico, because in that ECHO program, like it seems that at least the presenters are leading with a harm reduction approach. But maybe that's just like a subset of providers. And I just want to get a sense of where are we in New Mexico?
Yeah, well, I mean, in terms of, the basic things that people think of with harm reduction, which is, the syringe exchange and naloxone and things, we have pretty much led the rest of the country on that for over 20 years now. In fact, this year is the 20th anniversary of our legislation that has allowed us to distribute naloxone directly to people who may need it, and 23rd year of doing needle exchange. So we were the second of still only 2 states that not only legalize providing services like this, but actually mandated it in state law that the Department of Health was going to find a way to get services like this, to people who need it. And so, I think there's been so many things that have kind of built off of that attitude, or sort of that approach to this. New Mexico has never been a wealthy state, and this made a lot of, not only practical sense, but fiscal sense 20 plus years ago. And, I was working at Department of Health when ECHO was formed. I was part of those original meetings and things, to begin make Hep C treatment accessible to folks in rural communities. And, it's evolved into all of these amazing things that we can do. I would still say it's relatively recent that the kind of collaborations and things that are happening, where you more and more often are finding many of us in the same room together, like sort of working on figuring out how all of these things relate to each other. And, that in and of itself, it's still unusual in some parts of the United States. I think there's still places where it's illegal. There are places where they are pulling the plug on programs right in the middle of HIV outbreaks and overdose and everything else that's happening. And I think that, when we started doing naloxone distribution 20 years ago, and I was going around the country and presenting on our data with it, some of the pushback was always, well, if you guys are doing this and all these lives have been saved, how come your overdose rates haven't changed? And, used to be a little confused by that until, the unfortunate developments nationwide for the past, 10 decade now, where, New Mexico went from being number one. In 2014, we dropped to number 2 behind West Virginia, and now we're all the way down at, I think, we dropped farther down. I think we're back up at like number 12 or something this year in the country, and our rates haven't really changed all that much, but we have managed to keep the lid on this, where places all over the country got caught totally unprepared by the things that are transpiring. And so
Thank you, Phil.
Yep.
I will say, Raquel, there was a time when harm reduction was a bad word and nothing could get funded that had the word in it. Even in the last year, there've been at least 3 articles in the New York Times about how harm reduction is becoming more mainstream, and you'll find out more about it. I know Dr. Ketcham has a last word to say, but before I turn it over to him, because we're really done with time, I want to thank Lynette. And Lynette, you can't see the chat, but many, many people thanked you for sharing your story here with us today. And I only wish we could have seen you and your dog, because I heard you were going to bring your puppy. So I'm sorry we didn't get to see you. Big hearts to everyone. Eric, do you want to say some last words before we close?
Yeah, just the question was, where are we, I guess as a society in addressing this? We have a long way to go still, unfortunately. I mean, I think we've come a long way in the last, few years. A lot of the work that I do is working with the American College of Emergency Physicians, doing advocacy. That's what takes me to DC to speak to Congress and such. But providing education for emergency physicians across the country. And I think we've made a huge shift within the specialty of emergency medicine to get more emergency physicians engaged. And I think we're getting more and more hospitalists engaged, and we're getting more people in primary care outpatient medicine, but we still have a whole lot of stigma stuff to work through, and a whole lot of concepts that we still have to educate about, and the issues that come up. Well, how long do I have to be on this medication, or how long should my patients be on this medicine? And the idea that, well, we only want to give them really short prescriptions for this, like we got to watch them so carefully. And it's like, but you're treating a disease. I mean, you'd give people a 30-day prescription for their antihypertensive or their, their hypoglycemic or their asthma medicine, but you're going to be so restrictive on this medication and have your patient jump through all kinds of hoops. I mean, it really is crazy, but we've made doctors now so afraid to prescribe other opioids, and unfortunately they lump buprenorphine in there. And I mean, even if you look at your PDMP reports, right? If you go and you get a New Mexico PMP report, I mean, I get flagged every year. I'm an aberrant emergency physician prescriber because they don't even have a category for addiction medicine specialists on the New Mexico PMP report, right? I mean, these are the kind of things that we still have to work through. And I have to explain every year why my prescribing of buprenorphine is so abnormal, for an emergency physician. And so these are, we have so much more work to do, and so much work of educating patients and families and our colleagues, because people still think this is something you're just supposed to be on, a short period of time, then you got to get off this. And I have a lot of patients the same thing. Wow, I hear you're stuck on buprenorphine forever. And I said, how long have you been injecting heroin? 12 years. It's like, well, would it be great if you had to take this for 12 years, but every day you can take it once a day and it's legal, and you don't have to, commit crime to get it, or sell your body or anything else, or you just go take this like you live a normal life.
I know. I hear so many people say they just love being normal again.
Yeah.
I want to thank everyone for joining us. We're going to have to close it down. We did have a session on microdosing, and there may be information on our website. But if not, you can also reach out to Dr. Ketcham, who can tell you about microdosing. And we look forward to having everyone join us at our next session. Thank you, Christina and Catherine and Anne Marie for organizing this. And thank you to all of our guests, Dr. Ketcham, Gadomski, and especially Lynette. Bye, everyone.
Thank you guys. Thank you very much. Bye-bye.
Bye-bye.